Yeah, welcome. This is Dr. Raju Devde, Professor and Head of the Department, Pharmacology, Kaktiya Medical College, Warangal. Today, the topic for discussion is anticholinesterases, or they are also called as indirectly acting cholinergic drugs. The reason why they are called as indirectly acting cholinergic drugs are, as you know, this anticholinesterases or cholinesterase inhibitors or indirectly acting cholinergic drugs which inhibit the enzyme cholinesterase. Okay, so by inhibiting the enzyme cholinesterase, they primarily inhibit acetylcholinesterase, but they can also target the butyrylcholinesterase, which is also called as pseudocholinesterase. Okay, so by inhibiting the enzyme cholinesterase or pseudocholinesterase, they are going to increase the acetylcholine. Okay, so that is why they are indirectly called as cholinomimetic drugs or indirectly acting cholinergic drugs. Okay, when you look at the mechanism of action of these, as the structure of anticholinesterases, they resemble that of acetylcholine. They bind to the acetylcholinesterase and inactivate them. Hence, acetylcholine is not hydrolyzed and it accumulates. And these actions of all the drugs are due to accumulation of acetylcholine. Hence, the actions are similar to that of the cholinergic agonists or cholinomimetic drugs. So with this brief introduction, we will move on to our drugs. Okay, so these anticholinesterases, as I told you, they inhibit the cholinesterase enzyme from breaking down acetylcholine, hence increasing both the level and duration of action of acetylcholine. So this enzyme, acetylcholinesterase, is the enzyme that hydrolyzes and thereby deactivate the acetylcholine after it binds to the receptor. And this enzyme is present both in the peripheral and the central synaptic sites. It is also present in the erythrocytes and in the placenta. Now, acetylcholinesterase enzyme has a tree-like structure with non-functional stem holding a tetramer over it. And this basic unit of the enzyme, which is a tetramer with a molecular weight of 3.2 lakh, each of the protomers contain an active site. And not only that, the stem is a collagen triple helix that seems to have a structural role only. And in the neural and electroplex tissue, the enzyme trees-like stem with tetramers are anchored in the basement membrane and the neurolemma, a porous collagen-rich structure. Apart from that, it has an active site of acetylcholinesterase, comprises two distinct regions, which is called as the anionic site, which contains the glutamate residue, which binds to the basic choline moiety of the acetylcholine. And it also has an esteretic site, which is containing the histidine or serine, okay, moiety. So that means to say the acetylcholinesterase comprises of two distinct regions. One is the anionic site, which is containing the glutamate residue, which binds to the basic choline moiety of acetylcholine. And also it has an esteretic site with a residue of histidine plus serine moiety. And as with other serine hydrolysis, the acidic, that is acetyl group of the substrate, is transferred to the serine hydroxyl group, leaving transiently an acetylated enzyme molecule and a molecule of free choline. So the spontaneous hydrolysis of the serine acetyl group occurs rapidly, and the overall turnover number of acetylcholinesterase is extremely high. Over 10,000 molecules of acetylcholine are hydrolyzed per second by a single active site. So that is the reason why this acetylcholine, as I told you in the previous class, which is rapidly hydrolyzed over 10,000 molecules of acetylcholine are hydrolyzed per second by a single active site of the acetylcholinesterase. So this is very important. Now, if you look at the mechanism, as I already told you, the structure of acetylcholinesterase contains an anionic site and an esteritic site, where because there are two types of cholinesterases available in the classification. We have reversible cholinesterases and irreversible cholinesterases. So these reversible cholinesterases accept edrophonium. So these reversible cholinesterases except edrophonium bromide bind to both the anionic and the esteritic sites, whereas the edrophonium binds only to the anionic site, and the binding is quickly reversible in minutes. Hence, this edrophonium bromide is very short acting. Whereas if you look at the organophosphates or organophosphorus compounds, which bind only to the esteritic site, but the enzyme is phosphorylated by covalent bonds and the binding is stable. So with some organophosphorus compounds, the binding takes many days to be reversed, while with others, it is not fully reversible at all. So that is the reason why when you talk about the reversible cholinesterases, the binding is there, but it is not as obstinately binding like the organophosphorus compounds, which are binding to the esteritic site very obstinately by the covalent bonds, which are the strongest bonds. So once the organophosphorus binding takes with the acetylcholinesterase enzyme or the esteritic site of the acetylcholinesterase enzyme, which takes many days to be reversed, while some of the organophosphorus compounds, it is not at all reversible. So this is very important. So that is why in the classification of what you call like the anticholinesterases or the indirectly acting cholinomimetic drugs, which are classified as reversible anticholinesterases and irreversible anticholinesterases. So what are these reversible anticholinesterases? These are compounds which function as reversible, competitive or non-competitive inhibitors of the cholinesterase, are those most likely to have therapeutic uses. Okay, so they are used therapeutically. Which ones are reversible anticholinesterases? They are having therapeutic uses, and these include the carbamates, the physostigmine, neostigmine, pyridostigmine, ambinonium, dimicarium. Okay, they are the carbamates. So this is very important. Then coming to the phenanthrene derivatives in this reversible category of anticholinesterases, we have galantamine, then we have piperidine derivatives like donepezil, tacrin, also known as tetrahydroaminoacridine. Tacrin is called as tetrahydroaminoacridine. And we have this edrophonium bromide, as I already told you. We have huperzine A. And when you talk about irreversible inhibitors of anticholinesterases, these are the compounds which function as irreversible inhibitors of the cholinesterase enzyme and are those most likely to have use as chemical weapons or pesticides. And they include organophosphorus compounds. We have parathion, malathion, ecothiopate, etc. So when you talk about this indirect acting cholinergic agonists like reversible acetylcholinesterase inhibitors like edrophonium, physostigmine, and neostigmine, they are the carbamates which have slow hydrolysis compared to the acetylcholine. So when you talk about the pharmacological actions of these anticholinesterase compounds, the actions are similar to that of the cholinergic stimulation, as they cause accumulation of acetylcholine. And the quaternary ammonium compounds like neostigmine are poorly absorbed from the GIT, and they do not cross the blood-brain barrier and have mostly the peripheral effects on the skeletal muscles. Which one? The quaternary ammonium compounds like neostigmine. Okay, they do not, because they are quaternary ammonium compounds. they are poorly absorbed from the GIT, and they do not cross the central nervous system. They do not cross the blood-brain barrier. Hence, they mostly have the peripheral effects on the skeletal muscles. And the lipid-soluble compounds like physostigmine and organophosphates are well absorbed from the GIT. They also reach the central nervous system and have both central and peripheral effects. Which one? Physostigmine, they cross the blood-brain barrier. Organophosphates also cross the blood-brain barrier, and they also have both the central nervous system and the peripheral nervous system effects. And these anticholinesterases, they stimulate both the sympathetic and the parasympathetic ganglion. And on the CVS, the parasympathetic effects predominate, leading to bradycardia, hypotension, negative inotropic effects, and cardiac output. It reduces. That means to say there is a fall in the blood pressure. And in higher doses, the blood pressure may increase due to stimulation of the sympathetic ganglion. So when these drugs, that is the anticholinesterases, are given in high doses, or they are taken in high doses, they will increase the blood pressure due to stimulation of the sympathetic ganglion. And the effect on the GIT, the respiratory tract, and on the eyes are as similar to that of the cholinomimetic drugs. And in higher doses, anticholinesterases can cause convulsions followed by coma and respiratory arrest. But these anticholinesterases at the neuromuscular junction, low doses increases the force and strength of contraction with fibrillations and fasciculations, but with high doses, they cause persistent depolarization and may result in paralysis. That is what is seen especially in organophosphorus compound poisoning. In high doses, you can see persistent depolarization and it may result in paralysis, whereas in low doses at the neuromuscular junction, it may increase the force of contraction and strength of contraction, resulting in fibrillations or fasciculations, especially which is seen in organophosphorus compound poisoning. So this is regarding the pharmacological actions of the anticholinesterase agents. It could be either say reversible anticholinesterases or could be irreversible anticholinesterases. Okay, now when you look at the various types of reversible anticholinesterases, for example, if you look in this particular slide, donepezil, it has a duration of action of 24 hours, which can be given orally, and it is used in the treatment of Alzheimer's disease. You take hydrophonium bromide, as I told you, it only acts by combining with the anionic site. It is not binding to the esteric site. Hence, the duration of action of this hydrophonium, it is 10 minutes, which is given intravenously. And this is actually useful as a diagnostic tool to differentiate between the myasthenic crisis or the cholinergic crisis. Okay, hydrophonium bromide test, which is used IV, it is called as a tensilon test to differentiate between whether it is a myasthenic crisis or cholinergic crisis. Suppose if it is myasthenic crisis and you give hydrophonium bromide in a test dose, the myasthenic weakness, the patient with myasthenia gravis will improve. But if it is cholinergic crisis, if you give hydrophonium bromide, then the weakness increases. Okay, that is the thing. Then when you talk about this neostigmine, the duration of action is 2 to 4 hours. It can be given orally, subcutaneously, or intramuscularly, especially in the treatment of myasthenia gravis. It is used in the treatment of post-operative urinary retention and post-operative abdominal distension. Then physostigmine, the duration of action is extending up to 1 to 5 hours. It is given intravenously as an antidote for curative-form drug toxicity, topical use in the glaucoma, for treatment of glaucoma, intramuscular or intravenous administration of physostigmine for reversal of central nervous system effect of antimuscarinic drugs such as atropine. In atropine poisoning, the antidote is physostigmine. Not only that, if you look at the pyridostigmine, the duration of action is 3 to 6 hours, and it can be given orally, intramuscularly, intravenously. For orally, pyridostigmine is given for the treatment of myasthenia gravis. When it is given intravenously, it is an antidote for curative from drug toxicity. And when you look at tacrine, the duration of action is 4 to 6 hours given orally in the treatment of Alzheimer's disease. These are some of the drugs which are reversible inhibitors, especially which are used in the treatment of various conditions. For example, if I take physostigmine, physostigmine, it is also called as eserine. It is an alkaloid which is obtained from the plant Physostigma venenosum. It is also called as the Calabar bean. So this particular physostigmine, it is lipid soluble tertiary ammonium compound, and hence it has better penetration into the tissues and also crosses the blood-brain barrier. So it is available, as I told you, in the form of an injection also, IV injection. It is available as 0.1 to 1% eye drops, and in combination with pilocarpine nitrate as 2% drops. And the uses of physostigmine for the treatment of glaucoma, it is used as eye drops and can cause brow ache as a side effect on long-term use. It can also cause retinal detachment and cataract. And it is also used in the treatment of poisoning, especially in atropine and tricyclic antidepressant poisoning. Physostigmine can be given as 0.5 to 1 milligram oral or 0.5 milligrams intravenously. When you talk about neostigmine, so this neostigmine especially is a synthetic quaternary ammonium compound which is poorly absorbed from the gut, and it does not cross the blood-brain barrier. So this neostigmine, it does not cause the blood-brain barrier, whereas physostigmine, it crosses the blood-brain barrier. So neostigmine does not cross the blood-brain barrier. So neostigmine enhances the skeletal muscle strength and increases the force of contraction in myasthenia gravis by anticholinesterase activity, by direct stimulation of the nicotinic neuromuscular receptors or nicotinic muscular neuromuscular receptors or NM receptors, and by enhancing the amount of acetylcholine released during each action potential. So here, hence, neostigmine is used in the treatment of myasthenia gravis. Okay, so when you compare the difference, or when you compare the differences between physostigmine and neostigmine, physostigmine, it is a natural compound. Neostigmine, it is a synthetic compound. So the intestinal absorption of physostigmine, it is very good, whereas neostigmine, it is very poor. When you look into the chemistry of physostigmine, it is a tertiary ammonium compound, whereas neostigmine, it is a quaternary ammonium compound. Absorption of physostigmine is orally, it is very good. Neostigmine, it is not at all absorbed orally. Tissue penetration with respect to physostigmine is good, whereas tissue penetration is very poor with neostigmine. Regarding the crossing of blood-brain barrier, physostigmine has both CNS and peripheral effects because it causes the blood-brain barrier, whereas neostigmine, it does not cause the blood-brain barrier. It has only peripheral effects. Hence, physostigmine is used in the treatment of glaucoma, and it's used in the treatment of poisoning like atropine poisoning, whereas neostigmine, it is only used for the treatment of myasthenia gravis, and it is used in the treatment of Curare poisoning, that is neostigmine, Curariform poisoning. So this is that is regarding the differences between what you call like the physostigmine and neostigmine. And when you talk about the pyridostigmine, it has similar effects as that of neostigmine, but it is longer acting when compared to that of physostigmine. Whereas physostigmine, it is 1 hour to 5 hours, whereas pyridostigmine, it is around 6 hours. Okay. And this hydrophonium bromide, I told you, it is a quaternary ammonium compound and binds to only the anionic site. It is a rapid and short acting drug, like 10 to 20 minutes its duration of action is, and it is used in the diagnosis of myasthenia gravis, and intravenously hydrophonium is also used in the snake bite and in curiform poisoning. We also give neostigmine in snake bites also. Now, when you talk about this rivastigmine, of course, this reversible cholinesterase inhibitors, we do have rivastigmine also, This rivastigmine, it is a drug which is having a longer acting drug, which is a carbamate compound that somewhat selectively binds to the acetylcholinesterase in the brain. This drug being high lipid soluble, rivastigmine is rapidly absorbed and reaches the brain and augments the cholinergic transmission in the brain. Hence, rivastigmine is used in the treatment of mild to moderate Alzheimer's disease when it is started in the dose of 1.5 milligrams twice daily, and the dose may be gradually increased at 2 weeks interval to a maximum of 6 milligrams BID or twice daily dosing. So rivastigmine is also a very important drug which is also used in the treatment of Alzheimer's disease, which is a reversible cholinesterase inhibitor. And not only that, we have another drug which is called as donepezil. So this donepezil is another reversible anticholinesterase drug with longer duration of action, which can be given once daily in the treatment of Alzheimer's disease. And this donepezil is shown to improve the symptoms of Alzheimer's disease. And the dose of this donepezil is 5 to 10 milligrams once daily tablet it is given. Okay. Then of course we have tacrine. As I told you, tacrine, it is also a drug which is having a lipophilic activated molecule which enhances the acetylcholine levels in the brain and has been used in the Alzheimer's disease. But the only problem is the tacrine, it is hepatotoxic, and therefore its role is very much limited. Or probably this tacrine we are not using nowadays because of its severe hepatotoxicity. When you talk about galantamine, galantamine is similar to that of rivastigmine with a good oral bioavailability of 90%, and the dose is 8 to 16 milligrams twice daily in Alzheimer's disease. Okay, so this is regarding the reversible anticholinesterases, which are definitely having lot of therapeutic uses in today's practice. Then when you talk about the irreversible inhibitors or irreversible cholinesterases, so these irreversible cholinesterases generally the irreversible cholinesterases are especially the organophosphorus compounds. Okay, they are the irreversible cholinesterases. They are powerful inhibitors of acetylcholinesterase enzyme. They bind with the enzyme in a stable. The binding with the enzyme is stable by covalent bonds, and they bind only to the esteretic site, and the enzyme is phosphorylated. So once the enzyme gets phosphorylated, the effects are similar to that of the cholinergic stimulation as acetylcholine accumulates in the tissues, and all the organophosphorus compounds except ecothiophate are highly lipid soluble and hence are absorbed from all the roots including the intact skin. So this makes organophosphorus compound poisoning possible even while insecticides are used for spraying the plants. So there is a lot of cutaneous absorption. Okay, so that is regarding the irreversible anticholinesterase agents. So they bind obstinately with a stable enzyme, or with the enzyme is stable by the covalent bonds, which are the strongest bond, and they bind to the esteretic site, and the enzyme become totally phosphorylated. Okay, so that is the basic disadvantage between the reversible anticholinesterase and irreversible anticholinesterase. As I told you, if you look at this particular thing, irreversible cholinesterases like ecothiophate, isofluorophate, and malathion. So here, these are the phosphoesters, right? And this isoflurane, the phosphorylated enzymes, you see, this binding to the acetylcholinesterase enzyme, and this enzyme gets phosphorylated, and it is very this enzyme will get very slow hydrolysis. So the enzyme which is binding the organophosphorus compound which binds to the enzymes, which very slowly gets hydrolyzed, and there is a lot of accumulation of what you call like acetylcholine in the tissues. and this is due to acetylcholine toxicity. Okay, so if you look at this echothiophate, the receptor specificity is 1 week or more. The hydrolyzed by cholinesterase, and the route of administration. So the uses are very less actually, but it can be used in the treatment of glaucoma and accommodative esotropia when it is used for topical ocular use. Isofluorophate, receptor specificity is 1 week or more. The topical ocular use is for glaucoma and accommodative esotropia. Then we have malathion, which is used. It also has a receptor specificity of 1 week or more specificity. The topical solution is used for pediculosis or lice. The parathion or malathion, they can be used for pediculosis. Okay, and of course we have this diisopropyl fluorophosphate, caducephores and cycloserine, dimethoate, and the reversible anticholinesterases, short acting, as I already told you. There's hydrophonium bromide, which is a quaternary ammonium compound that binds to the anionic site of the enzyme only, and the ionic bond formed is readily reversible, and the action of the drug is very brief, used especially for the diagnostic purposes, especially of the myasthenia gravis and cholinergic crisis, myasthenic and cholinergic crisis. And then of course we do have medium duration of action anticholinesterases. They are neostigmine, pyridostigmine, which are again quaternary ammonium compounds of clinical importance. Physostigmine, it is called as eserine, a tertiary amine, which occurs naturally in the Calabar bean. These drugs are all carbamyl compounds as opposed to astyls, esters, and all possess basic groups that bind to the anionic site. Okay. Now, the irreversible anticholinesterases, especially, these are the pentavalent phosphorus compounds containing labile groups such as fluoride in diflos, or an organic group in parathion and malathion. The group is released, leaving the serine hydroxyl group of the enzyme phosphorylated, and they interact with the esteratic site of the enzyme, and no cationic group is formed. And echothiophate is an exception in having a quaternary nitrogen group designed to bind only to the anionic site. So that is why echothiophate is used in the treatment of glaucoma. And the inactive phosphorylated enzyme is usually very stable. Now, if you see this particular acetylcholine is binding to the esteratic site, or it is binding to the anionic site, that is due to electrostatic attraction, and the serine moiety is binding to the esteratic site, and this is the enzyme acetylcholinesterase. Finally, it gets hydrolyzed to acetic acid and choline. Okay, but in the presence of organophosphorus compounds, these are organophosphorus compounds, they obstinately bind with the esteratic site, and this acetylcholinesterase, it binds to the what you call like the organophosphorus compounds to the esteratic site, whereby it cannot hydrolyze the acetylcholine, and there's accumulation of acetylcholine in the tissues. Now, this is again the same thing. We can just forward this. Then regarding the physostigmine, I already told you, it is also called as eserine, and it is derived from Calabar bean. It is a parasympathomimetic in nature, specifically a reversible cholinesterase inhibitor. It is an alkaloid derived from Calabar bean. It acts by interfering with the mechanism, with the metabolism of acetylcholine. It indirectly stimulates the nicotinic and muscarinic receptors also, and it is used in the treatment of myasthenia gravis, glaucoma, Alzheimer's disease, and delayed gastric emptying. And it is recently has begun to be used in the treatment of orthostatic hypotension. Physostigmine, it is an antidote of choice for datura stramonium poisoning and curare, and it is also an antidote of atropa belladonna poisoning. Coming to the side effects, the overdose may cause cholinergic syndrome, and other side effects include nausea, vomiting, and diarrhea, and anorexia. Neostigmine, it is a parasympathomimetic drug, and specifically a reversible cholinesterase inhibitor, and it is available under several treatments like prostigmine and vagostigmine. The clinical uses of neostigmine are myasthenia gravis, and routinely in anesthesia at the end of an operation to reverse the effects of non-depolarizing skeletal muscle relaxants such as rocuronium and vacuronium. So it reverses the uh, non-depolarizing skeletal muscle relaxant action, especially for reversing the anesthesia. And then pyridostigmine, I told you, like it is again a reversible cholinesterase inhibitor, quaternary amine. It is poorly absorbed from the GIT and doesn't cross the blood-brain barrier, except possibly in stressful conditions. It may cross the blood-brain barrier. Whereas this pyridostigmine is used in the treatment of myasthenia gravis and to also used to combat the effects of curiariform drug toxicity, and is also used in the treatment of orthostatic hypotension. The side effects of pyridostigmine are nausea, vomiting, diarrhea, abdominal cramps, increased salivation, tearing, and increased bronchial secretions. And apart from that, edrophonium, again, it is a very short-acting acetylcholinesterase inhibitor. It prevents the breakdown of the neurotransmitter acetylcholine and acts by competitively inhibiting the acetylcholinesterase mainly at the neuromuscular junction. And this irreversible anticholinesterase like malathion is an organophosphorus compound which binds irreversibly to the cholinesterase, and it is an insecticide of relatively low human toxicity, whereas the risk of malathion itself is low toxicity. However, absorption and ingestion into the human body readily results in the metabolism of its metabolism to melloxin, which is substantially more toxic. And the medical use, especially therapeutic use for head lice and body lice. And parathion, also called as parathion ethyl or parathion diethyl parathion, it's an organic phosphate compound, also a potent insecticide and acaricide. But the safety with respect to parathion is a cholinesterase inhibitor, generally disrupts the nervous system by inhibiting the acetylcholinesterase, and the absorption via the skin, the mucous membranes, and orally, it is rapidly metabolized to para-axon as described. And this para-axon exposure can result in headaches, convulsions, poor vision, vomiting, abdominal pain, severe diarrhea, unconsciousness, tremor, dyspnea, and finally lung edema as well as a respiratory arrest may occur. It is mainly used as an insecticide, but there might be a poisoning which may occur, or there might be accidental or suicidal or tendency of poisoning with this particular drug can occur. Then if you look at difloss, that is diisopropyl fluorophosphate, DFP, is an oily colorless liquid with a chemical formula C6H14FO3P. It is used in medicine as an organophosphorus insecticide, and it is stable but undergoes hydrolysis when subjected to moisture, producing hydrofluoric acid. So it is known also under the names difluorophosphate, diflufil, difluorphate, difloss, difloss, fluorophryl, and so on and so forth. And apart from that, this diisopropyl fluorophosphate has been used in ophthalmology as a miotic agent in the treatment of chronic glaucoma, and as a miotic in a veterinary medicine, and as an experimental agent in the neurosciences because of its acetylcholinesterase inhibitory properties and ability to induce delayed peripheral neuropathy in the experimental animals. So it induces diisopropyl fluorophosphate as an meiotic in veterinary science and as an experimental agent in neuroscience because of its acetylcholinesterase inhibitory properties and ability to induce delayed peripheral neuropathy. It is known as fluorostigmine and difloss in such uses. Now, uses as toxin. Diisopropyl fluorophosphate is a very potent neurotoxin. So it has a LD50 for rats, that is 1.3 milligrams per kg, where it combines with the amino acid serine at the active site of the enzyme acetylcholinesterase, and the enzyme that deactivates the neurotransmitter acetylcholine. And the neurotransmitters are needed to continue the passage of nerve impulses from one neuron to another neuron across the synapse. And once the impulse has been transmitted, acetylcholinesterase functions to deactivate the acetylcholine almost immediately by breaking it down, hydrolyzes it down. So if the enzyme is inhibited, acetylcholine accumulates and the nerve impulse cannot be stopped, causing prolonged muscle contraction, resulting in paralysis, and death may result since respiratory muscles are also affected. So that is how it acts as a toxin. Then when you talk about these organophosphorus compounds, so organophosphorus compounds sometimes are abbreviated as opiates or organophosphates, not opiates, organophosphates. Is a general name for esters of phosphoric acid. So organophosphates are esters of phosphoric acid, and these phosphates are probably the most pervasive drugs. They cause a lot of toxicity, and they are actually the pesticides or insecticides or pesticides compounds, but they are sometimes used for poisoning, also for homicide and suicidal tendencies. And these organophosphorus compounds, many of the most important biochemicals are the organophosphates, include the DNA and RNA, including the DNA and RNA, as well as many cofactors that are essential for life. And these organophosphates are also the basis of many insecticides, herbicides, and the nerve gases, like the carbon, serine, and so on. The structural features of these organophosphates, they mainly are effective. Organophosphates have the following structural features: a terminal oxygen which is connected to the phosphorus by a double bond, which is called as phosphoryl group, and two lipophilic groups bonded to the phosphorus are present, leaving a group bonded to the phosphorus, often which is a halogen in nature. And when you talk about this organophosphorus compound poisoning, it mainly the organophosphorus compound poisoning, which may be either an acute toxicity or a chronic toxicity. So the organophosphorus compounds are used as agriculture and domestic insecticides, and poisoning by them is very common in our Indian context. And this poisoning may be occupational poisoning, as while spraying the insecticides, or accidental, or for suicidal tendencies. The symptoms result from muscarinic as well as nicotinic and the central effects. And the presentation of this acute toxicity is ranging from vomiting, abdominal cramps, to diarrhea, meiosis, sweating, increased salivation, tracheobronchial secretions are increased, the gastric secretions are increased, there is a bronchospasm, there is hypotension, there is muscular twitchings, weakness, convulsions, coma, and death. Death may be due to respiratory paralysis. So this is regarding the organophosphorus compound poisoning. There's acute poisoning. And these organophosphates are also potent nerve agents, functioning by inhibiting the action of acetylcholinesterase in the nerve cells. They are one of the most common causes of poisoning worldwide, and are frequently intentionally used in the suicides in agricultural areas. And their toxicity is not limited to acute phase, however, and chronic effects have long been noted. And the neurotransmitters that are acetylcholine are profoundly important in brain development, and many organophosphorus compounds have neurotoxic effects on the developing organisms, even from low level of exposure. And the signs of OP poisoning, I already told you: salivation, lacrimation, urinary incontinence, defecation, GI upset, emesis, meiosis, and so on and so forth. So along with that, if you look at the treatment of the organophosphorus compound poisoning, it is not only the spontaneous hydrolysis of phosphorylated cholinesterase is extremely slow, a fact that makes poisoning with organophosphorus compounds very dangerous. So, keeping this in context, you should know that the enzyme is becoming phosphorylated, and it becomes obstinately bind to the esteritic site with the organophosphorus compound. This acetylcholinesterase enzyme binds obstinately and it becomes phosphorylated. So the treatment of organophosphorus compound poisoning, if the poisoning is through skin, we have to remove the clothing and wash the skin with the soap and water. And if the OP compound is consumed by oral route, a thorough gastric lavage must be given, and the patient should be put in the prone position to avoid aspiration of the secretions. And also we have to maintain the blood pressure and to keep the airway patent. Now, what is the treatment of choice in this particular situation? OP poisoning, organophosphorus compound poisoning, because it becomes very crucial as there is a spontaneous hydrolysis of the phosphorylated cholinesterase enzyme, and the hydrolysis is extremely slow, and the fact that makes the poisoning with OP compounds very dangerous. So what is the next drug of choice? The drug of choice is atropine. So it is an anti-muscarinic drug. Atropine is an anti-muscarinic drug. It is given intravenously, 2 milligrams every 10 minutes till the pupils are dilated, or we say full atropinization. And the maximum dose of atropine can be anything from 50 milligrams to 100 milligrams, or even more depending on the severity of the poisoning. The treatment should be carefully monitored because of the risk of reappearance of the symptoms due to delayed absorption of organophosphorus compounds, and hence atropine administration may often be needed up to 3 to 4 weeks duration. And we have this cholinesterase reactivators. So as I told you, the cholinesterase reactivators like pralidoxime. Not only that, we have obidoxime and diacetyl monooxime, DAM, PAM, obidoxime and DAM, pralidoxime, obidoxime and diacetyl monooxime. These oxime compounds, they combine with the cholinesterase organophosphate complex. They release the binding and set free the acetylcholine enzyme. Thus, they reactivate the cholinesterase enzyme. So these cholinesterase reactivators should be given within minutes after the poisoning, preferably immediately, or within 1 to 2 hours, to prevent the aging of the enzyme. So aging of the enzyme is something where there is phosphorylation which has occurred. So the organophosphates have bound to the esteritic site of the acetylcholinesterase enzyme so obstinately. So once it is bound very obstinately, it cannot be cleaved, and the hydrolysis of this enzyme becomes very critical, or it becomes very much impossible, and there's a lot of accumulation of acetylcholine, and the effects pertaining to the muscarinic effects, the nicotinic effects, the central nervous system effects, and so on and so forth may result in fatality. So the cholinesterase reactivators and atropine anti-muscarinic drugs have to be started very promptly and immediately. They should be given within minutes after poisoning, preferably immediately, before the complex undergoes aging and the enzymes cannot be released. So we have to give these compounds like either anti-muscarinic drugs or the cholinesterase activators before the aging of enzyme takes place. So the complex becomes more stable by loss of chemical group, and thus is responsible for aging, and it is difficult to break the complex. So what is this complex? The complex is nothing but the binding of the organophosphorus with the esteritic site, forming a complex which becomes very difficult for the cholinesterase reactivators to break the bond, and hence the cholinesterase reactivators are not useful in poisoning due to carbamate compounds, that is the organochlorinous compounds or carbamate compound, because these compounds do not have a free site. The anionic site is not free for binding of the oximes. Moreover, pralidoxime itself has weak anticholinesterase activity, particularly at higher doses. and the rate at which the aging occurs varies from a few minutes to several hours with different compounds. So in severe poisoning, when I want to give cholinesterase reactivators like pralidoxime, I have to give 1 to 2 grams of intravenous pralidoxime within 5 minutes before the aging takes place and yeah, during the organophosphorus compounds, they give very best results. And in the medical practice or in the treatment of poisoning, it is rather uncommon for the patient to get such quick treatment within minutes, particularly in the rural setup. And the cholinesterase reactivators are tried up to a few hours with a maximum of 6 hours after poisoning. That means to say, actually speaking, when you want to give anti-muscarinic drugs or the pralidoxime or cholinesterase reactivators, they have to given very immediately. But in the context of the rural setup, it is very difficult for the patient to bring from rural areas to the tertiary care, where we give the treatment, that is the treatment of poisoning is taken place, where we can give this pralidoxime or obidoxime and or what you call like the DAM, PAM obidoxime or DAM, diacetyl monoxime, up to 6 hours, presuming that the aging of the enzyme does not take place up to 6 hours. That is from few hours to the maximum of 6 hours. And beyond that, these drugs will not help. So this diacetyl monoxime it is a lipid soluble, and therefore it can cross the blood-brain barrier and it can regenerate the cholinesterase also in the brain. So this DAM or diacetyl monoxime has an added advantage to pralidoxime and obidoxime because it is high lipid soluble, so it can cross the blood-brain barrier and it can regenerate the cholinesterase enzyme which is present in the brain. So it is more superior to pralidoxime or obidoxime. That is your diacetyl monoxime. And not only that, if you look at this is regarding the management of organophosphorus compounds in the acute management or acute states. Okay, so before that, I would like to tell you a brief regarding the treatment of organophosphorus compound poisoning. Suppose if I give an anti-muscarinic drug, that is atropine, how does this atropine act in the treatment of organophosphorus compound poisoning? So this atropine, it blocks the muscarinic receptors and it reverses the muscarinic symptoms like excessive salivation and all those things. Okay, secretions and all those things. So therefore, the atropine, it becomes life-saving and it is a drug of choice in organophosphorus compound poisoning. And nicotinic symptoms are not reversed by what you call like especially the atropine. So it only reverts the muscarinic symptoms. So when you talk about the next aspect, when you give this cholinesterase reactivators, they are called as oximes or pralidoxime, obidoxime, and diacetyl monoxime. These bind to the cholinesterase organophosphate compound. So these oximes, they bind to the cholinesterase organophosphate complex and they cause release of cholinesterase enzyme. And this released cholinesterase enzyme with the obstinately bound organophosphate cholinesterase complex gets degraded and with the release of acetylcholine. And so this cholinesterase degrades the acetylcholine, which is accumulated in the various tissues and in the various areas of the body, and it reverses all the symptoms. And to note that this particular oximes have to be started early to avoid aging of the organophosphate cholinesterase complex. And they are not these oximes, they are not very much useful in the carbamate compound poisoning or organochlorinous compound poisoning. So when you talk about the chronic organophosphorus compound toxicity, some of the organophosphorus compounds can produce neurotoxicity or they may produce polyneuropathy several days after the exposure of the compound. And this toxicity has come to light when thousands of people develop paralysis in America after consuming Jamaica ginger, so which contained small amounts of TOCP, that is triorthocrysyl phosphate. So this triorthocrysyl phosphate, which has resulted in development of symptoms including weakness, fatigue, ataxia, sensory disturbances, muscle twitching, and in severe cases, it caused flaccid paralysis, which may last for several years. So this chronic organophosphorus compound toxicity also has to be monitored, where in America there was one drink which consisted of Jamaica, the drink which was called as Jamaica ginger, and which contained a small amount of TOCP, that is triorthocrysyl phosphate, which has resulted in development of what you call like the in severe cases it resulted in development of flaccid paralysis. So that is the reason why we have to use these particular we have to monitor for chronic organophosphorus compound poisoning also. Okay, that is regarding the management of OP poisoning. So with this, actually we have looked into what you call like the reversible anticholinesterase agents, its therapeutic uses, and irreversible cholinesterases, and the irreversible cholinesterases, especially they are the drugs which are the organophosphorus compounds, the carbamates and OP compounds, and the carbamyl compounds and organochlorinous compounds. And these actually are used as pesticides, insecticides in farming, the agriculture, but most of the times this organophosphorus compound poisoning occurs maybe either accidental, or it could be some suicidal, or could be some poisoning may occur due to cutaneous absorption, because they are very well absorbed to the cutaneous route also. And this reversible cholinesterases, especially which are used therapeutically, like physostigmine, neostigmine, pyridostigmine, rivastigmine, donepezil, edrophonium, galantamine, tacrin. So this physostigmine, neostigmine, pyridostigmine, they are mainly useful in the treatment of, say, for example, either for treatment of glaucoma, they are used for the treatment of myasthenia gravis, or for the reversal of the Curare form effects, or reversal of skeletal muscle relaxants, as well as this donepezil, galantamine, rivastigmine, they are used in the treatment of Alzheimer's disease. And the edrophonium bromide, it is also a reversible cholinesterase inhibitor, which is binding to the anionic site of the acetylcholinesterase, which is having a very short duration of action. And this particular drug is given intravenously for diagnostic purpose to differentiate between the myasthenic or the cholinergic crisis, and the test which is called as Tensilon test. And with this, probably I think I have finished this anticholinesterase drugs. So anticholinesterase drugs, as you know, they are also called as indirectly acting cholinomimetic drugs. So they are the reversible cholinomimetic drugs, indirect acting cholinomimetic drugs, as well as irreversible indirectly acting cholinomimetic drugs. So whenever you talk about these anticholinesterases, means that they are going to inhibit the enzyme acetylcholinesterase. So by inhibiting the enzyme acetylcholinesterase, the hydrolysis of acetylcholine, which is accumulated at the level of the synapses, is decreased, and there is more accumulation of acetylcholine, resulting in various effects of these acetylcholine. And in some situations like glaucoma, or in the peripheral muscle disorders like myasthenia gravis, we do require the acetylcholine concentrations, where the drugs like reversible drugs or cholinesterases are used. So with this, I think I have to come to the end of my talk, that is acetylcholinesterases, or we call like yeah, anticholinesterases. Thank you.